Hey everyone, it's Izzy. Sorry I couldn't be there for the CBI Open Close today, but I decided to follow in Adrian's footsteps and record my slide set. So if you have any questions, please feel free to reach out to me. But for my learning objective, number one, it's to define aneurysm and describe the locations and types of aneurysms. So I'm going to talk about these various types listed below right here. To start, I thought we would review the microanatomy of a muscular artery, so that way we can try to make sense of where these different lesions are occurring when you think of aneurysms. So the three walls that comprise an artery are the tunica intima, tunica media, and the tunica adventitia. So you can see here, the intima is the most inner or intimate layer. I like to think of it that way, so innermost. And you can see here that it's described as a single layer of endothelial cells. So it has this subendothelial layer, the endothelium right there, and then it also has a little bit of an elastic lamina there. Then moving outwards, you have your tunica media, the middle layer, and that has a higher proportion of smooth muscle compared to elastic arteries. So right here, we're talking about more of a muscular artery. And it separates, you have this external elastic layer here, and that's what helps separate the tunica media, so this middle portion, from this tunica adventitia, the outermost. The tunica adventitia, or outermost layer, is primarily comprised of loose connective tissue, and you can kind of see these striations here on the image that I think are trying to depict that. And a unique thing about this layer is primarily it has the vasa vasorum, which is a blood supply in large arteries, and it has the nervi vasorum, which is autonomic nerves that help with that smooth muscle dilation and constriction. So there are various types of aneurysms, but in general, an aneurysm is thought of as a bulge or defect in the vessel's integrity. So in that vessel wall, those layers we just talked about. So different layers can be affected, and that's kind of how we differentiate what type of aneurysm we're dealing with. So you could have intima, media, adventitia, all three, or just a couple of them affected, depending on the aneurysm type. So a true aneurysm is defined as all three layers being compromised. A false aneurysm or pseudoaneurysm is when the vessel wall is perforated and it has a formation of a hematoma extravascularly, and we can kind of see that here. It's almost like bulging outward because the vessel integrity right here is compromised, so then you have this formation of the hematoma. And then we'll talk a little bit more about dissecting aneurysms, which we can see right here. You kind of have like two lumens, essentially, that the true lumen and then this false lumen that gets formed. Another aspect of this learning objective is to discuss the various types of shapes, essentially, that aneurysms can take. So we have our saccular, fusiform, and berry. So to start with, a saccular aneurysm is asymmetrical dilation. So it's less common and has a higher rate or higher risk of rupturing compared to fusiform. So right here we can see saccular. You have this true lumen here, and then saccular is kind of just like this extra addition, extravascularly, I guess you could kind of look at it that way. Almost like I don't know, it kind of like reminds me of like maybe some sort of like tumor, like attached extra, like in an extra space next to it. I don't know, maybe that helps. But on the contrary, fusiform is this equal symmetrical dilation. So you see this normal diameter here, that would have been like the true lumen. And we can tell right here we're working with the abdominal aorta because we can see our IMA and iliac vessels here. And so here you can see this continuous, like equal dilation all across, and this is the most common type of aneurysm shape. The third was berry aneurysms, and you probably remember this from NS2. So these are really common causes of subarachnoid hemorrhages. You have this formation of a berry aneurysm right there at the anterior communicating artery in the circle of Willis. And they also kind of just take like this little round, bulging saccular shape. And those typically tend to happen where vessels converge or at a junction, which the anterior communicating artery is a perfect location for that. So a thoracic aneurysm, this is when you have dilation of all three layers of the aortic wall, so the intima, media, and adventitia, and this is when they reach greater than 150% of their normal diameter. So this would be defined as a true aneurysm since all three layers are compromised. On ambos, they had the ascending aorta approximately dilates greater than 5 centimeters, and descending would be greater than 4. I'm not completely sure in essentially like what, if that's like a hard threshold or there's just differences in ascending versus descending. So I'm not completely sure about those measurements. But thoracic aneurysms in general are a little less common than the AAA, and they tend to have a peak incidence of patients ages 60 to 65. They also said there's a 3-to-1 male to female ratio. So we'll talk about another one that kind of has a higher male incidence or prevalence, you could say, but I'm not completely sure if that's just because of diagnostic, like maybe they're diagnosed a bit better in males, or what the true kind of relevance of the sex-based differences are. But I think it's important to just remember that these can happen in any patient and they're true emergencies. So your patient might present with chest pain. They might report some thoracic back pain, difficulty swallowing just due to your esophagus being in that region. Hoarseness, because depending on the dilation or aneurysm, you could get the recurrent laryngeal nerve affected. So just thinking about that, especially when we're working in this area. Another interesting finding could be Horner syndrome, and on a chest x-ray, you would see a widened mediastinum. And I'll show you that on this slide. So on the right here, we can see a normal chest x-ray and compared to that of having a thoracic aneurysm. So you can see here the mediastinum is very much enlarged in this one. And then you can kind of see right here this difference. They tend to point to the aortic knob to kind of like get your bearings, I guess. And I'm not a radiologist, obviously, but I thought this was helpful to kind of see just how enlarged it is compared to normal. Abdominal aneurysms are localized dilation of all three layers of the abdominal aortic wall. So again, another true aneurysm because intima, media, and adventitia are included. And this can be greater than or equal to 3 centimeter dilation. Again, similar sort of peak incident age of 60 to 70. Smoking is a huge risk factor for an abdominal aneurysm. So also atherosclerosis, hypercholesterolemia, and arterial hypertension, and trauma. So there can be various sort of things in your patient's history that may potentially point to this. You can localize abdominal aneurysms kind of in 2 regions, and you use the renal arteries as kind of your baseline. So if you have below the renal arteries would be an infrarenal abdominal aneurysm, and that's the most common location. About a third of those extend into your iliac arteries, but just kind of wanted to highlight that infrarenal is a bit more common. And then suprarenal would just be including area above the renal arteries, which are right here. They can take a saccular or fusiform shape, and we talked about those earlier on in the presentation. A dissecting aneurysm, basically what happens here is that you have that tear in the intimal layer, and then it separates your arterial wall layers, and then you get that formation of a second false lumen, which there was a really good picture on one of the earlier slides showing that. A clinical example of this would be an aortic dissection. So you'd have a tear in the aortic intima. That blood would be able to enter the media and forms that false lumen in the what's called the intima media space. And then you get this formation of a hematoma, which right here you can see with these black arrows. So this is all hematoma. And when you see that, that's indicative of a dissecting or ruptured aneurysm. And the hematoma can kind of continue to progress longitudinally across the arterial wall. And you can see that here on this image. Dissected aneurysms can rupture, which we saw with that other picture of the stain. That formation of a hematoma points you to a ruptured aneurysm. And some risk factors for an aneurysm rupturing is if the aneurysm expands really quickly, has a really large diameter, and just gives out. Smoking or tobacco use can all lead to rupturing of the aneurysm. And your patient might present with hypotension because it might be a loss of blood, so hypovolemic shock, sudden onset of really severe tearing back or abdominal pain. That's kind of like the classic words you'll hear if something's kind of pointing you to a ruptured aneurysm. And the pain can radiate to the flank, buttocks, legs, or groin. It can present with a painful mass. They could have nausea, vomiting, syncope, hematuria, and some other clinical signs you can look for, which I thought were interesting, is a Cullen sign. Both of these are basically just bruising ecchymosis that you would see on physical exam, but a Cullen sign is right there inferior to the umbilicus, and then gray Turner sign, you would see ecchymosis like all across the flank area. So you can see this patient's laying on their back, and that's kind of like or their hip, and then leading back into the flank area. And this one is gray Turner, while the umbilicus one is the Cullen sign. This is another good image from Amboss, and it kind of shows you what you're looking at. So this right here is our true lumen, you could say. And then you see these perforations here. Those are the false lumen, and we can see that here. So that's why I put a good CT image, and you can kind of see they look like two lumens next to each other. So that's just kind of a good way to visualize what's happening when we talk about these intima media adventitia tears. And this is more like a clinical image of it. So right here, we can see our tearing here, and this is described, I didn't go into detail about this, but basically you can describe these aneurysms as different. They're Stanford type or DeBakey type. So this one right here is considered DeBakey type 1. But with this arrow here, you can kind of see these two lumens next to one another. And this is a CT image axial view. But yeah, just to kind of correlate the cartoon images with a CT image. And those are my references. I primarily used Amboss, and I really highly recommend it. And then this Radiopedia website is really good looking at images. So if you have any questions, please reach out to me. And I look forward to seeing you guys for the next CBI. Thank you.